And I was just thinking, because of the kind of the things that you have been mentioning, I was just thinking we might just kind of have a kind of we already have a series of speakers right now, but I was just thinking to bring up one of the talks. I'm not sure if Ghazaleh is already online, because her talk is just exactly following what you have been presenting. So I was thinking that we can start with Ghazaleh talk, and then we can go for the other kind of talks that we already have. Ghazaleh, are you online right now?
Yes. Thank you so much for organizing this webinar, and thank you for your invitation. I really enjoyed all of previous presentations, and in the next few minutes, I'll be talking about optimizing dose in brain stimulation studies. Next, please. I'd like to start with this figure from the first INTAM paper. You can see that in our previous systematic review, most of TS and TMS studies for addiction medicine placed the stimulating electrode or TMS coil over the dorsolateral prefrontal cortex. And when we updated our systematic review by May 2022, we found that 66 out of 75 TS trials used symmetric or asymmetric electrode montage for targeting DLPFC. Next, please. And when we simulated these two electrode montages for 66 participants with methamphetamine use disorders, as you can see, first we found a very huge inter-individual variability in terms of electric field strength and electric field distribution patterns. And next. Group-level analysis of computational head models also showed that maximum electric field is not located under the stimulating electrode. And when we extracted electric field hotspots for both methamphetamine users and healthy controls, methamphetamine users in red and healthy controls in green, we found that hotspots were located in the superior frontal gyrus, and such that medial frontopolar area received the maximum electric field. And when we compared the electric field intensity inside the frontopolar area compared to a 10 millimeter sphere around the F4 location over the cortex as the center of a stimulating electrode, we found a significantly higher electric field in medial frontopolar area. So it seems that in most of previous TS studies for addiction, frontopolar cortex play an important role. And next slide, please. And as introduced by Dr. Fox in Jutsa and in a recent lesion-based study proposed by Jutsa and colleagues, it had been reported that frontopolar is the area that had greatest association with addiction remission, and this brain region was introduced as the ideal target for excitatory neuromodulation. And next slide. And also, deep TMS coil with H4 or H7 coils, as presented by Dr. Fox, that received FDA approval for smoking cessation, also induced a strong electric field over the frontopolar area. But these two types of deep TMS coils conventionally viewed as stimulating insula or lateral prefrontal cortex. And next slide. It seems that in most of previous TS and TMS studies that showed promising results in the field of addiction medicine, I mean, for example, bilateral or unilateral DLPFC stimulation by large electrodes over DLPFC or deep TMS coils, or even figure 8 TMS for modulating frontopolar cortex, frontopolar area received a strong electric field. And we have also some other evidence from fMRI data. Next, please. And during fMRI drug reactivity test, we found a significant activation inside the frontopolar cortex in drug versus neutral contrast. And when we calculated the task-based connectivity between frontopolar area and other parts of the brain, we found decreased PPI connectivity between frontopolar cortex and middle frontal gyrus, where DLPFC is located. And we also found increased PPI connectivity between frontopolar area and some subcortical regions that play important role in Q exposure, such as amygdala, nucleus accumbens, hippocamp, and cingulate cortex. And next slide, please. We also have some interesting results from dose-response relationship analysis for frontopolar area. And we found that frontopolar is the area that electric field intensity is related to the response to TDCS, such that higher electric field intensity in the frontopolar correlated with greater board signal change in drug versus neutral contrast in methamphetamine users. And in a larger cohort, next slide. In a larger cohort, we also found a significant correlation between normal component of the electric field inside the frontopolar area and board signal change in drug versus neutral contrast in in this brain region. Based on these findings from lesion-based study, computational head modeling, or fMRI drug curie activity maps, or dose response relationship analysis, I just want to emphasize that despite the majority of studies targeting DLPFC in substance use disorders, it seems that frontopolar area could contribute to many of previous clinical outcomes in substance use disorders, and probably it can be considered as a target in future studies, but more research is needed to optimize the target, to optimize the stimulation dose, and ultimately to maximize the clinical benefits of these types of stimulation for various substance use disorders. And thank you so much for your attention.
Thank you, Ghazaleh. So it just, yeah, it's in line with what what Mark was presenting. I'm not sure if Colin has a specific kind of specific comment about that, because it seems that the medial frontal prefrontal cortex is the area that Target has been targeting for quite a long time.
Yeah, I think it's all really exciting, and not only because it bridges what like Fox and Justa and their group has done with lesion mapping. We know from our preclinical friends that do animal studies, the medial prefrontal cortex has causal relationship to drug self-administration. So optogenetic stimulation of this area changes drug self-admin. Right, and then plenty of people on this call have done neuroimaging studies that show functional connectivity to this area as associated with relapse to various drugs. We've been targeting it. We've moved a little bit from the ventral aspect to the dorsal medial aspect. I know some other groups are too. It's fun times.
Okay, now we have a series of other discussants discussing about the optimization and how we can optimize the kind of stimulation protocol that we have for drug addiction. And I mean, I'm sure that we will have other discussions in terms of how we can move forward for the next steps. The next speaker is going to be Dr. Victor Tang from CAMH from Canada. Victor, are you with us?
Yeah, I'm right here. So hi everyone, it's great to be here and to see such a wide audience here. It's very exciting. I'm Victor Tang. I'm a new addiction psychiatrist and clinician scientist at the University of Toronto. And I'm just going to be taking a few minutes to talk about designing TMS clinical trials and how we can think about optimization at the patient level and patient level factors. Next, please. And just a quick second on my disclosures. So the first idea I want to discuss is that to get the data required for individualization that is eventually going to translate to clinical practice, we need to include in our trials the complexity that we see. Next. And the basic idea is that the patients that come into our clinics present with complexity and comorbidity. Like this figure from SAMHSA suggests really briefly, is that people that walk in with a substance use disorder will likely also have another mental illness or a different substance use disorder. So that behooves us to think about, conducting trials that look within and between diagnoses as well, such as this great trial on deep TMS in unipolar depression, bipolar depression, and unipolar depression with alcohol use disorder. Next. And so this is something that we're trying to do in a pilot RCT we're wrapping up for deep TMS plus varenicline in smoking cessation, which is that we took basically everybody that wanted to quit smoking and was interested in brain stimulation. And as you can see from our table 1, we basically had a plethora of different mental illnesses on the SCID, as well as baseline drug screen had a lot of comorbid substance use as well. And so the idea is, can inclusivity help with our trials and future individualization? Next. And another way to cut across this heterogeneity is to think about primary outcomes that more focused on neurobiologically based endophenotypes. And this is a great review paper I love from a few years ago from my colleagues in Toronto, and also includes Dr. Hanlon, which basically looked between addiction and major depressive disorder literature. So it was meta-analyses of functional imaging and reward, meta-analyses of functional imaging in value appraisal, and then to drug cues for addicted patients and negative stimuli in major depressive disorder. And the idea is that there was this large overlap with the ventral medial network, which suggested that the commonality here is some sort of incentive salience disorder that could possibly be targeted with our trials instead. Next. And so everybody's familiar with this kind of 3-stage model of addiction well publicized by INIDA, that includes incentive salience, but as well, next, the prefrontal cortex, which is often a target of stimulation, which actually underlies executive function. Next. So then the question is whether we can target, common symptom clusters between comorbid conditions. And this is something we're trying to do in Toronto in a recently launched large cohort study across all addictions looking at executive function, called the Cognitive Dysfunction and Addiction Study. And we embedded this pilot RCT looking at executive dysfunction specifically as a target in comorbid major depressive disorder and alcohol use disorder. And we're also doing a similar idea with another pilot trial where we're targeting suicidality as a symptom cluster in comorbid MDD and opioid use disorder. Next. And so the last thing I want to touch upon is whether we can optimize TMS by increasing accessibility. Next. And so what we know is that addictions treatment is really the most effective when it's highly accessible, low barrier, and very flexible. And a lot of my colleagues here in Toronto, including Dan Bloomberger, have really paved the way into thinking about how can we design trials that basically make things more efficient and save time and make things more practical. Next. And so sometimes we're thinking that, one way to do this is to look at electrical field modeling for existing approved coils, like this BrainsWay FDA coil that was recently approved for smoking, and think about what are the barriers, which is usually things like cost and travel and intensity of staffing needs. And next, whether we can, look at similar electric field models in other coils, such as, these circular coils, which are cheaper, more accessible, require less technician burden, and see if there are overlapping electric field models that kind of stimulate the same area. Next. And can be adjusted to target our regions of interest too, like the insula, just by different targeting. And so they've done a lot of work on this in depression, and we're interested in trying to move this forward with addiction because, again, we want to make things more accessible. Next. So that was just a couple points that I thought that would be interesting to address. Once again, I'm Victor Tang of Toronto, and this is just a quick list of all my great mentors and collaborators here in Toronto. Thanks so much.
Thank you very much. Thank you very much, Victor. It was a really nice presentation. It's great to have a nice group of people in Canada doing kind of brain stimulation in CAMH and other things. I just realized that we have Tony George here online. So there are lots of kind of exciting things happening in Canada as well. The next speaker would be Dr. Tonisha Kearney-Ramos from Colombia. And Tonisha is one of the rising stars in the field. Tonisha.
Oh, thank you, Ahmed. Thank you. So I wanted to talk to you guys a little bit about the parameter space in individualized TMS trials. Next. I feel like what I'm going to talk to you about is kind of a summary, but also kind of a summary of what you've heard, but also kind of impressing upon you the need to really think about the types of parameters that we should be considering in our studies or even in our clinical populations. And so, obviously there's a very wide parameter space, and what I've included here is by no means an exhaustive list of things that you should be thinking about. But some of the things have already been mentioned by some of the other speakers. So one really important thing might be the target location determination. So how you're actually identifying the target. Some of the things that we've seen so far include the using imaging paradigms to evaluate regions that overlap across individuals where they may vary across individuals, and sort of identifying lesions maybe that overlap, or even using e-field maps and how they overlap with functional maps. There's so many different ways, and there's a lot of research in the field using different approaches, and so it's really important for us to consider designing studies that will really get at the mechanisms that most closely relate to treatment response. There's also things that we were talking about, I think, before the talk started, like the session schedule. So how many sessions you do in a day, for instance, might be an accelerated paradigm where you're doing multiple sessions in a given day. And depending on how many sessions you're doing in a day or in a week, how does that really translate into improved outcomes for our research participants or for our clinical populations? There's also biological factors, which I'll get to in a moment, and then clinical and demographic factors. So what about the disease stage that an individual is in, disease severity, how long they have been using the substance of interest, or whether or not they're on any other concurrent they're undergoing any other concurrent treatments, how does that confound our outcomes as well if they're taking additional medications or they have other comorbid disorders. So I wanted to highlight, if you could go next, I wanted to highlight here, I'm going to start off really, really basic and talk about scalp to cortex distance. Next. Yeah. So one really important principle that I don't think anyone has touched on, but this is something that many of you may already know, but I'm speaking also to some of you that may not already be in the field and doing this kind of work. There is a principle of TMS which is related to the stimulation depth. So the Maxwell's equations determines that there's a rapid decay in the stimulation depth, the influence of the electric field with depth. Next. And in fact, most figure 8 TMS coils really only reach about 2 centimeters into the there's only a depth of about 2 centimeters. For H coils, it can reach to about 4 to 5 centimeters. Next. Now the good thing is that the cortex is really only about 2 to 3 millimeters thick. However, next. There's a great deal of variability in the distance between where the coil is actually placed on the scalp and the underlying cortical tissue. And this can be for a variety of reasons. It can be the thickness of the fat layer underneath the skin, the bone, the skull bone thickness, or even the dura beneath the skull and above the cortex. And so there's research that has come out next that has really looked at the fact that there has to be, there's a linear increase in the stimulation intensity required to actually induce stimulation of the cortical tissue based on the distance itself. And so there are now tools, if you go to the next slide, that we can actually use either in a research setting or a clinical setting to use imaging methods to actually measure the scalp to cortex distance and use these either as covariates in your research or as ways as parameterizing or adjusting the for the scalp to cortex distance, adjusting the stimulation intensity required to for a given individual. Could you go to the next slide? So in thinking back just about the biological factors, next. Some speakers have already kind of talked, so we've talked about scalp to cortex distance. There are also differences in the interplay between the electric field and the actual orientation of the axons and how that then precipitates the action potentials that are induced. So these are all factors that we really need to be investigating further to understand the implications in a given individual in our research in clinical populations. Several people have already talked about, Colleen, for instance, has already talked about baseline brain state and how the variability in the baseline brain state can actually influence the magnitude and direction of the response that we get. And we're still kind of piecing, together what exactly the mechanism for that might be. Next. One thing that we can do is harness this idea of priming. So where we actually induce a given brain state at baseline by shifting it either through conditioning stimulation or through a physiologic activity like behaviorally engaging that circuit. As Colleen mentioned, the research that came out for OCD and smoking have that in their protocols where you actually induce a given brain state and use that brain state or shift that brain state then with TMS. And so that's one way of actually getting around the influence of baseline brain state as the variability in that brain state. Another factor that people may not be thinking about is the fact that there are genetic polymorphisms that have been associated with variability in plasticity potential. And so this is another thing that we might need to be thinking about is how does, a given individual's SNP or whatever SNP they have for BDNF, for instance, how does that influence the potential for them to act, for us to manipulate the brain into a given state, and whether or not we should be looking at that at baseline as well. So this is just a really brief summary of some of the things that maybe we should be considering and including those in our research as well. Thank you.
Thank you very much, Tonisha. Was a really, really nice presentation. Thank you. Thank you very much. Our next speaker is Dr. Vaughn Steele from Yale, and Vaughn is one of the leaders of thinking how we can individualize the TMS trials for people with substance use disorder. Vaughn, please.
Oh, yes. Yeah, thanks for inviting me, Hamid. This has been great. Hopefully you can hear me all right.
Perfectly well.
Yeah, great. Yeah, so I'm Vaughn. I'm here to talk to you about this part of the parameter space. As everybody's talking about, parameter space is huge. So talk about how we individualize circuit-based interventions. So go ahead, next. Just my disclosures, I'm a consultant. I have some funding that's currently covering most of my research. Next. So one of the ways to better understand circuit-based intervention is go to maybe a more mature field. And it's been a decade now since Mike published his influential biological psychiatry paper showing different targets in DLPFC have downstream effects on subgenual ACC, which is putative location of modulation that's related to positive outcomes in depression. More recently, Robin Cash has shown that these little balls in the left DLPFC, as you get, that's where people are being stimulated versus where their target site, optimum target site would be in relation with resting state connectivity, how that's related to outcomes here in the MADRS. You can see a reduction in MADRS is increased as you get, well, it's a better decrease as you get closer to your optimum site. So these are sort of clues as to how we might use functional connectivity, at least resting state, or circuit-based interventions with targetable cortical targets for stimulation. So next, please. This slide is sort of a review of people who are here, right? So Mike did a great job talking about how we use lesion studies to identify differing targets that are cortical seeds for, figure-of-8 RTMS coils for remission of addiction. Much of Tonisha and Colleen's work showing how it gets very complex once you start looking into the brain. White matter tracks are very important underneath the coil. So is gray matter density underneath the coil have influential effects on downstream bold signal, which could likely lead to downstream behavioral effects that we want to induce with TMS as intervention. Also, baseline state is important. Here's a measure of Tonisha's recent work showing striatal Q reactivity. As that increased at baseline, people were more reactive and they showed greater reduction in Q reactivity after TMS. So the state that somebody's in is actually very important for identifying which circuits you're modulating and then if they're malleable or not. Next slide, please. Continuing on this state trait, there's some work that's been more than a decade now showing in nicotine users that if they're abstinent and then given either placebo or nicotine patch, some circuitry does not change. So it's more of a trait circuit. This is a connectivity with dorsolateral prefrontal, well, with dorsal anterior cingulate cortex on the left there. And then other circuitry is more malleable in the state context. If you think about if you're on-off nicotine, dorsolateral prefrontal cortex to insular functional connectivity is actually malleable, suggesting we might need to worry about malleability of a circuit when we're specifically targeting a circuit. Next, please. So although it's a large parameter space, all is not lost. I've done some of this work already in the upper left where I find circuitry that's related to treatment outcomes in both imaging and ERPs. Nobody's presented event-related potentials here. This is a really good measure of cognitive functions and circuitry and such. So I'll be beating that drum for a while. And I use those to develop the accelerated ITVS treatment that I did for cocaine use disorder when I was in Baltimore at NIDA. And that chronic application actually did reduce cocaine use a month out and other drugs of abuse as well. So it suggests that this is a great circuit-based and cognitive function-based intervention theme to develop targets. Also, Travis Baker's group, thanks for him sharing the slide with me on the bottom, showing that in the active group, reward positivity can be modulated with RTMS interventions. And he can show in the 4 blocks, in the first 2 blocks, RTMS is not applied. In the last 2 blocks, they are. So it's a specific intervention with RTMS. Again, ERPs are useful ways of measuring these things along with imaging. So the parameter space is huge. I have some commentaries, and I highlight the review that I did that identifies some of the parameter space that should be discussed. Much of it's been discussed here, but further reading, because I only had 5 minutes. And that's all I had. Thanks for listening.
Thank you very much, Vaughn. It was a really nice presentation. Thank you very much. Now we go from US to Netherlands. We have Debbie Klooster. Hello, Debbie.
Yes, hello. Thank you so much for having me. Hi everyone. Indeed, my name is Debbie Klooster, and I'm actually from the Netherlands, but I work in Belgium. I'm from Ghent University, and I would like to start this presentation with an overview of just standard T1 weighted MRI scans subjects we specialize to get that we don't have to wear them. The images are rather small, but they do not align 100%. I'm sure that we all know that these things are not similar. So I want to start with a question, and that's like, why do we use generalized brain stimulation protocol? Like, why do we use one-fits-all brain stimulation protocols to treat all kinds of, well, different brains? So in this presentation, I would like to talk more about a proposal, and that is the use of individual brain characteristics derived from multimodal neuroimaging to personalized brain stimulation protocols. And then obviously the optimal goal in the end is to make brain stimulation treatment more effective for a broad variety of neuropsychiatric disorders, amongst which also addiction. And next slide, please. So in this very short presentation, I would like to focus on personalizing two stimulation parameters, namely the positioning of the coil and also a bit on the stimulation intensity. We have recently proposed methods to personalize RTMS parameters for depression treatment. And to personalize the coil position, we proposed a 3-step process. And in the first step, we used a priori information about the pathology to define the region in the brain that we actually want to target. So this can be a deep brain region, and for example, in case of depression treatment, this can be the subgenual anterior cingulate cortex. And this region can be shown on anatomical MRI data. Next, please. So in the second step, we use results from previous studies who showed that the effects of TMS pulses propagate throughout the brain via functional and structural connections. So if we use functional MRI or diffusion-weighted MRI data, we can use functional connectivity maps or diffusion-weighted connectivity, so structural connectivity maps, and we can find cortical locations that are connected to this indirect target, so this deep brain region. And this cortical target can directly be stimulated by the TMS coil, assuming that we use a figure of 8 coil. And next, please. Then, as a third step, we want to use electric field simulations to find the coil position and orientation that actually optimally target that predefined cortical brain region. So electric field simulations can be performed for a couple of positions. So for example, for a grid of positions over the cortical target, then we can also vary the orientation of the coil, and then we can use an optimization algorithm to find the position and the orientation to actually optimally target the intended cortical region. And next, please. So this 3-step process was suggested to optimize coil positioning for depression treatment, but how can we translate this information to treatment of addiction? So specifically, I think the question then is, what is our stimulation target to treat addiction? So we just learned from Dr. Fox about his latest study in which he suggested concrete targets for brain stimulation for addiction treatment. So concretely, he suggested the medial frontal polar cortex when doing excitatory stimulation, or the frontal operculum or the paracingulate cortex if we want to do inhibitory stimulation. As you can see here, I put the indirect between brackets since nowadays the DTMS coil, the H1 from Brainsway, is known to be able to directly stimulate these brain regions, so they can stimulate deeper regions in the brain. And in that case, we would be able to simplify our 3-step process into a 2-step process. And next, please. Also, I would like to focus a bit more on the potential of electric field stimulation to derive the stimulation intensities. The electric field strength scale linearly with the stimulation intensity. So if we know what intensity we want to have in our stimulation target, we can do a reverse calculation to derive or actual stimulation intensity. I think this also indirectly incorporates the scalp to cortex distance, as was just mentioned by Dr. Kearney-Ramos. Sorry if I pronounce your name incorrectly. But the question here is still, what is the minimum electric field strength that we want to achieve in our cortical targets in order to really induce neuronal activity? Next, please. So the added value of personalization is logically reasoned, but still very speculative. So studying the added value of every personalized parameter separately is challenging, since these studies would require many samples. And it's also questionable how different personalized parameters relate to each other. So even though promising, I think there are still many challenges to overcome to achieve our ultimate goal, to make brain stimulation more effective for a broad patient population. Next, please. Okay, thank you. That was it. If you want to know more details, you can read the paper, and if you have any questions, feel free to reach out. Thank you very much.
Thank you very much, Debbie. It was a really nice presentation, and you're doing a really great job in terms of the optimization of TMS studies. And I think that people, I mean, there are many labs in Europe that are doing a really nice job in personalization of neuromodulation. And I think that we need to find a way to collaborate more with people in Europe to be able to extend these sort of activities across the world. So there are definitely lots of opportunities in these sort of collaborations. Our next speaker, do you have any comment on that, Debbie?
No, it's fine. Thank you.
Thank you. So the next speaker is going to be Dr. Cristian Morales Carrasco from here in Minneapolis. Cristian, are you online with us?
Yes. Thanks.
Yep. Thank you very much for joining us.
No, thanks to you for organizing this great seminar today. Well, so I'm going to talk here a little bit of how we have been working around doing some computational modeling for E-field, of the E-field or TMS interventions, and also how we target the position to intervene using functional brain networks. So next, please. Next. So, well, this is intended for TMS interventions, and basically what I mean when I speak about computational modeling is how we do the actual modeling of the electric field prior to the intervention, and also to identify the target region that we want to intervene. And we work basically here with a simulation software called SimNIPS that allows us to create a realistic model, a 3D model of each individual brain to run the electric field simulation. So that starts with an acquisition of a structural set of images, T1 and T2, and optionally a DTI or a diffusion image, to create a finite element model in which we can run the simulations. And on top of that, run several simulations to actually identify which position of the coil could reach the highest electric field intensity in a region to target. But the question is how to target the region, and that has been discussed a lot previously. But this approach that it can be done using anatomical information, anatomical landmarks for the specific participant, or using functional informed networks or connected areas using resting state in fMRI in this case. And then when we identify the region, once we identify the region, we optimize the coil position and run the simulation. And then we have we complete the process with having a projected electric field in the native space, for the participant. Next, please. So next.
Cristian, could you turn on your video as well? It seems that your video is not turned on. So
sure.
Not
okay, sorry. My apologies. Sorry.
Okay, now we can see you.
Okay, sorry for that. Next one, please. Okay, so in order to identify the target using the functional structure of the brain, we can use fMRI, both signal of fMRI. But in this case, we are studying from the literature. We know that to get to know reliably how the functional structure of the brain, we will need a highly sampled resting state sessions. So in previous work from Gordon et al. showed that after 20 minutes of a good data acquired from resting state session, we can reach a high reliability of the functional maps, plateauing after 40 minutes of good data. And that also assumes that we are very conservative in motion censorship, and we control for respiration or related movements. After we obtain that data, we can calculate seed maps connectivity, which is a specific region of interest connectivity, or we can use also functional brain architecture of the participant. So nowadays we know there are several techniques to identify the individualized brain structure, functional brain structure, as community detection algorithms or template matching. So we ended up having the functional brain structure or architecture of each participant. In case that we don't have the resting state data or functional images of participants, we still can use some template derived maps or like functional parcellations, Gordon parcellation, Yale parcellation, or these probabilistic maps. No? So this is a recently published study from the lab I work with. It's the probabilistic atlas, which shows at every core region in the brain what's the probability of that region to belongs to one functional network, and that can be already downloaded from that web page over there. That's work from MNC et al. Next one, please. Next, okay. So as an example, this is part I want to present a preliminary work that we're collaborating. We're working with in a collaboration with a psychology department here in the U. This is a project led by Brian Webler, which is trying to target hippocampus, which is a subparietal structure. So we don't have direct access to it. So the aim of the study is to target a cortical region that's connected to the hippocampus. So this is a project that aims to stimulate the hippocampus, and it will test if this intervention will strengthen the pattern separation or decrease fear generalization. So we place an ROI in the hippocampus, left hippocampus in this case, that was informed by Vaughn et al. Then we calculate the seed map for whole brain seed map, and then we find the regions that are connected to this seed within the PPC area, which is the cortical area that has been shown that it has functional connectivity with hippocampus. But on top of that, we calculated the brain network for these participants. So on top of that, the area has to be located in PPC. We restrict the search for an area that has a high likelihood or belongs to the default mode network for that specific participant. And the region has to be, this is an extra constraint, no? The region has to be located in the top of a gyre. That's mostly due to what was discussed before, no? So the decay of electric field through the cortex. The next one, please. Well, once we identify that cortical region for each participant, we run. We already have the seed map, the connectivity map, and we already have the simulation for that position. So for targeting the position. So the position was already calculated, identified. The coil position was already optimized using the same toolbox of CNIPS, and we can observe what's the intensity of electric field on top of the region that we want to target. And next one, please. And so what we have so far, so this is an ongoing project. So for this specific study, we identify or we reach a procedure to identify the target region to stimulate based on functional connectivity. And then we have observed so far that the variability between participants on the target position, it's not negligible. So we do see a high variability in space of the target region. but and using as an approach, and that's a result that was already seen in previous studies that use a similar approach to target TMS interventions in, for instance, the LPFC, where the between participant variability it's not negligible. No, okay. Next one, please. So these are some of the reference of the work, and next one, please. So I wanna thank the lab I belong to, the center I belong to, and the organizers of this amazing seminar. Thank you very much.
Thank you very much, Cristian. Thank you very much for presenting your exciting works with individualized TMS targeting. The next speaker is gonna be Dr. Lizian Bienel from NIMH, and the exciting part is people in different areas, not only in the field of addiction, they are working to see how we can have individualized TMS studies, and we can definitely learn from them and what they are doing to inform what we are going to do in the field of drug addiction. Lizian, are you with us right now?
Yes, I am.
Okay, thank you very much for joining us.
Thank you for inviting, and thank you for the introduction as well. And can you hear me okay?
Perfectly well.
Awesome. All right, so let's take a little step aside and talk about, cognitive study and the effect of TMS on working memory in that case. So in the earlier talk, we mentioned several ways to improve TMS efficacy. We talked about the brain state. We talked about when to stimulate with ERP, for example. What I'm going to talk about is the spatial targeting. So as you all know, there is different way we can target the brain with the new approaches. So we have anatomical MRI, functional MRI, then functional connectivity, and even now structural connectivity with some approaches such as network controllability that I will not be talking about today. Next slide, please. And next. All right. So I guess you all know this paper from Sack et al. In 2009. Basically, what they did is apply active or sham TMS with different targeting approaches. One of them was the P4, so EEG 1020 placements. Then we had some Tadera coordinates, MRI, and then fMRI coordinates. And what they found in this paper is that only with fMRI, they were able to find a difference between active and sham stimulation. And what's more interesting on the graph on the right side is that when you compare the effect size, basically with P4 placement, you would need about 45 subjects to reach a significant effect, defined by the p-value equal 0.05. But with fMRI, you reduce this number to only 5 subjects. So that's the first proof of evidence that fMRI is better than other targeting approaches. However, it was based only on 5 subjects per group, and it was a between group comparison, so not the best comparison. Next, please. So we conducted a meta-analysis of more than 100 studies using online TMS during cognitive processes, and we extracted the targeting methods for all of them. And so what we found there with this huge data set is that once again, fMRI is the significant predictor of TMS efficacy over other targeting such as hotspots or even anatomical MRI. Next slide, please. Okay, so individualizing using fMRI seems to be a good thing, but to what extent? And so what I want to show you now is the example from our working memory task that we conducted at Duke. And next, please. So we had participants doing some working memory task in the scanner, and we were defining the DLPFC as our area of stimulation because why not, right? Everybody is doing DLPFC anyway. And so what you can see on the second brain in the middle here, which is kind of tiny, but I hope you can perceive at least, each point represents the coil location for each specific subject. And you can see that it's spread out pretty much everywhere. So individualizing is good, but is it a good thing to be so variable, right? Are we targeting the same process in each subject? What we found, comparing active and sham TMS in this working memory, was that only in the hard condition, active TMS was able to enhance performances, but the coherence D was pretty moderate effect size, even small. So we thought, is it the best way to go? Should we constrain a little bit this individualization? And so next slide, please. This is what we did in our second experiment. So first change, we decided to switch from DLPSC to parietal activation because we found this huge spot, as you can see here. So we thought it must be more efficient in modulating working memory. And then, as I said before, we use a mask to constrain our target. Next, please. And so as you can see here, all the subjects were targeting more or less at the same location. So we reduced the variability, lead to this individualization. And we're hoping that by doing so, our effect size will increase. Next, please. However, that was not the case. So the D was pretty much the same. And we found, this is not relevant for this talk, but instead of improvement, we found disruption of performances. Next, please. All right, so fMRI is good. And the problem is when we use fMRI this way, we always think, okay, I want to stimulate this area, so I'll stimulate this specific node. We always think one-to-one, but the brain doesn't work in a one-to-one. It's a brain, it's network regions. They all communicate together. And what does it do really to apply TMS on one node? It doesn't just go to one single spot. It's spread out everywhere. And so what I'm showing you here is a review that we conducted using resting state functional connectivity. And so what I'm showing you is the different networks, so dorsal attention, ventral attention, frontal limbic, which I guess is more relevant in that case. And I'll be showing you on the top periodic stimulation, so everything classical from 1 Hertz, which will be on the left for conventionally inhibitory, and then 5, 10, 20 Hertz on the right for conventionally excitatory. On the bottom will be the pattern stimulation, so TBS, QPS, all these kind of fancier approaches. Next, please. And so what we saw here, each arrow represents where you send the stimulation, so on which network, and then where it goes is where the effect propagates. And so basically you can see if we focus, let's say, okay, on the frontal limbic network, so on the, it's hard without the mouse, sorry. On the bottom left, the FL, little circle there, you can see that when you stimulate the frontal limbic, you also affect a lot of other networks. And basically, what you can see as well, blue is an increase in connectivity, red is a decrease in connectivity. So when you use conventionally excitatory, we kind of have the effect we expect with an increase in connectivity to all other brain networks, but sometimes it also decreases. So we might need to be careful to what stimulation frequency is doing. And more interestingly and more surprising, I guess, is for everything with ITBS, so pattern and excitatory, you can see that the main effect of ITBS on connectivity is a decrease instead of the expected increase effect. Next, please. So what this is saying is the frequency might not be, oops, just lost my screen, sorry. Frequency might not be the only thing leading to the TMS effect, and we might need to consider other approaches, maybe the connectivity profile of the node. Is it negatively connected to another area? Is it positively connected? Maybe that matters as well. And this is something we need to keep exploring. And also, maybe everything is not about resting state, right? I'm always surprised when I hear this trend with resting state connectivity and then, you know, state dependency. I'm like, why would you use resting state in the scanner? Then in that case, use your task and stimulate with this, you know, approach. But let's discuss that after. And next slide, please. And I would like to thank you all for your attention. Thank you to my former Duke team, Dr. Applebaum being here right now. Thank you to NIH, Dr. Holly Lisenby, Dr. Luber, and everyone there. And thank you for your attention again.
Thank you very much, Lisan. It was a really thought-provoking presentation. And I think that there are lots of things that we still need to learn. And there are lots of really major challenges that we need to deal with in the next coming years. And yeah, it is always great to also report the negative results of the trials and what we are doing to just inform others how to move to the next level. Okay, so the next presentation will be Dr. Jonathan Young from Duke. Jonathan, are you with us?
Yes, I'm here. Great, thank you so much. Good morning, everyone. My name is Jonathan Young. I'm a staff psychiatrist at the Durham VA, and I'm on faculty at Duke. I mostly study the development of therapeutic TMS for smoking cessation in combination with psychotherapy and pharmacotherapy, particularly in veterans and PTSD, but more recently I've become interested in bioethics of TMS research. Next, please. First, I'd like to thank so much Dr. Aktari for the invitation and the other event organizers. I'm so honored and excited to be here, especially with such an internationally recognized group of scientists as my co-panelists. And huge shout out to my mentors, colleagues, and funding sources. Next, please. No relevant disclosures. My views are not those of my employers. So the outline today, I'm going to describe some core bioethical principles I believe are relevant to personalized TMS trials. Also, we'll briefly review some of the current literature, drawn mostly from the latest publication of the expert TMS safety guidelines. And lastly, I'll mention some limitations and future directions of this line of work. Next. So the core bioethical principles that apply to personalized TMS trials are relevant to all medical research, which includes respect for autonomy, beneficence, non-maleficence, and justice. While a comprehensive review of these is outside the scope of today's talk, I'll briefly describe them here and try to tie them into personalized TMS research. Next. So respect for autonomy is a bioethical principle that obligates us to respect self-determination of adults with decision-making capacity. And for personalized TMS trials, participants must have decision-making capacity to undergo informed consent, which includes an ability to understand the potential risks, benefits, and communicate in choice intentionally in the absence of controlling influences. Rule the truth, respecting the privacy of others, protecting confidential information, and obtaining consent for interventions. The principle of beneficence refers to the moral obligation to act for the benefit of others, which includes providing benefits as well as balancing benefits and risk harms. This principle forms the foundation for several rules to protect the rights of others, to prevent harm from occurring to others, to remove conditions that will cause harm, help individuals with disabilities, and rescue those in danger. For personalized TMS trials, this includes the development and funding of research that either directly or indirectly benefits patients. The principle of non-maleficence describes the obligation to not inflict harm on others. For physicians, this is related to the opening tenet of the Hippocratic Oath, first do no harm. This bioethical principle suggests that researchers should not cause pain or suffering for research participants. In the personalized TMS trials, there needs to be careful consideration of the unique risks and benefits of the proposed research in the target patient populations and the ways in which we can minimize these risks. Potential benefits of study procedures should outweigh potential risks, and enrollment procedures must reflect this. Generally, there are no long-term negative side effects we know of to TMS, but we are certainly aware of short-term risks such as induced seizures. Consequently, we must think carefully of the study's inclusion and exclusion criteria, particularly those that may increase seizure risk. And lastly, the principle of justice requires that we equitably distribute benefits, risks, costs, and resources. Applying the bioethical principle of justice to personalized TMS trials can be done at multiple levels. At the planning and development stage, we should be seeking to conduct therapeutic development using TMS for clinical populations with greater needs, such as those with less FDA-approved treatment options. This principle also requires us to equitably distribute access and enrollment. Potential participants must be evaluated consistently and systematically without bias within the limits set forth of the IRB. Additionally, findings, both positive and negative, must be published and reported so that patients may ultimately benefit. Next slide, please. So the latest version of the consensus TMS safety guidelines by Rossi et al. 2021 includes a section on the ethical aspects of performing TMS in healthy subjects and in patient populations. In the interest of time, I'll just quickly review a few of their recommendations, especially which include studies on interventions aimed at preventing or curing disease or alleviating symptoms of illness. Next, please. In therapeutic trials, study participants have some chance for individual benefits. In randomized control trials, a portion of participants have a chance to benefit from the active intervention. However, there's data to suggest that those in the inactive treatment arm may also benefit to an extent from placebo effect or just from the more intense monitoring and care. And this may play an even larger role in personalized TMS trials where neuroimaging and other procedures for neuronavigated targeting result in kind of more close monitoring and interactions. The paper also notes that acceptable risks and burdens kind of depend on the burden and risk of the disease and the anticipated benefits of the treatment, weighed against the risk of alternative interventions, which includes doing nothing, as well as required changes to certain medications or other ongoing treatments in order to enroll in the study. Additional considerations are a need for vulnerable populations such as pregnant women, as treatment may affect the unborn child. Next, please. Consistent with protections for human subjects in all clinical research trials, TMS trials should be conducted under a research protocol approved by IRB, and the protocol should specify the level of risk, the risk-benefit ratio, and the roles of every member on the team, and also specify the degree of medical supervision required, and also informed consent always obtained by an authorized individual. Next, please. So every interventional TMS trial should be registered in a publicly available database prior to enrolling the first participant. Guidelines also encourage reporting, like I said before, reporting about the positive and negative outcomes. It's also recommended to use standardized reporting modalities, forms, and classifications to allow for more accurate reporting and summarization of the safety data. And if you see the paper, there's a table that includes these classifications. And lastly, it's important to follow up on all severe adverse events with possible causality, such as seizures, but other severe adverse events such as cognitive changes, syncope, and suicidality should also be reported, even when the relationship to TMS is not clear. And then, of course, consider reporting not only to the IRB or Data Safety Monitoring Board, the manufacturer, but also the FDA. So in summary, I'll ask, when should bioethical, next please, when should bioethical principles be considered? So essentially throughout the process, you should consider these principles from developing a novel clinical intervention using TMS, protocol development, applications for funding, regulatory oversight, recruitment procedures, study implementation, and finally post-study. Next, please. A few limitations to note from the paper include that there was including a paucity on long-term outcomes. This, in addition, especially with new clinical populations and novel TMS-based interventions, there remain many unexpected and unknown risks. And these guidelines are based on expert opinion and available data, which for bioethical issues is largely secondary or retrospective in nature. Next, please. So future directions of blindness research will need to be more directed effort and funding to better understand these issues for many of the types of TMS. And indeed, some of my colleagues are planning to perform prospective studies evaluating both the experiences and perspectives of both patients receiving therapeutic TMS and their families. And we'll be considering some vulnerable populations such as pregnant women. Next, and thank you so much for your time and your attention. Thanks again for having me.
Thank you very much, Dr. Young, for such a nice presentation and opening another dimension, important dimension in what we do for individualized neuromodulation for vulnerable communities that we are working with. Thank you very much for bringing this up for us together. And now we are done with the sort of discussion presentations. And now we have the last talk by our speaker, Dr. Kevin Walton from NIDA. And Kevin has always been really supportive of what we have been doing in terms of bringing people together and encourage young generation of scientists in the US to apply for granting opportunities within NIDA to develop new interventions for substance use disorder. And thank you very much for accepting our invitation and joining us today as well. Thank you very much, Kevin.
Thank you, Hamid. I really appreciate the invitation, and this has been a wonderful meeting. I've certainly learned a lot, and I really enjoyed it. So I'm really glad here to share something about NIDA's support for neuromodulation, and the primary goal of mine is to make sure everybody understands that NIDA is very interested in these technologies. We really do see it as a very important aspect of developing treatments for substance use disorders, and so I just hope everybody understands that, and that I'm going to repeat this a few times for people who are interested in doing this research to reach out to program officials at NIDA. We're really happy to talk with you about your research. We'll review specific aims. We really want to see this kind of work progress and be successful. So now I'll just go a little bit into the weeds about the specifics. So we fund a lot of neuromodulation research Many of the ones, I think probably all the ones that were mentioned here, right? TMS, TES, deep brain stimulation, vagal nerve stimulation, focused ultrasound. We've funded grants on all these topics. We support research of preclinical and clinical, mechanistic studies, and therapeutic development. And then for therapeutic areas, everything that NIDA does, the tobacco, cannabis, stimulants, opioids, we've funded research for neuromodulation on all these topics. So it's a really broad portfolio. So now I just want to familiarize everybody with how NIDA is set up and then who funds what kind of research. So we have 4 different divisions, or well, 5 divisions or centers that fund research. So we have the Division of Neuroscience and Behavior, which focuses on sort of mechanistic and discovery studies. The Division of Therapeutics and Medical Consequences, which is where I work. So that is development of interventions as a therapeutic. So we do efficacy studies. The Office of Translational Initiatives and Program Innovations, they fund the small business grants. And so they're looking at commercial aspects of neuromodulation. The Division of Epidemiology Services and Prevention, it's sort of self-explanatory of what they do. So they will fund much less. So like phase 4 studies for something that's already approved and figuring out how to get it out to a wider population. That kind of research would fall into that division. And then the Center for Clinical Trials Network, they do neuromodulation research. Those projects are brought up through the centers, and so it's not a process that's generally open for investigator-initiated research. It's through the center's process. So the first 3 divisions, the first two divisions, and OTIPI are what I'm going to talk about. What kind of work that we do, what FOAs we have, and who you should reach out to. So okay, next slide. So Division of Neuroscience Behavior, it focuses on, as I said, mechanism and discovery. They'll do preclinical and clinical studies. And then there's a couple of funding opportunities I want to bring up. So these are not specifically focused on neuromodulation and devices, but that type of research can be funded through here. And then I also want to take a step back. So I'll be naming a number of FOAs, but certainly we fund research through the standard investigator-initiated R01, R21 mechanisms. So I'm not eliminating those. I'm just talking about ones now that might be of particular interest to this field. Exploratory clinical neuroscience research on substance use disorders. So talking about identifying and demonstrating engagement of a potential target prior to an efficacy trial. So this is an interesting mechanism. It's an R61, R33. So it's in 2 phases. The first one is 2 years. The second one is up to 3 years. And the idea is to de-risk this for NIDA and for the investigator. So the R61 would focus on more short-term goals and milestones that would then allow us to support a larger study that would ask more broader or perhaps more expensive questions. But it's a really useful mechanism that we find helps us fund perhaps riskier research. And then the Brain Initiative, Biology and Biophysics, and Neural Stimulation and Recording Technologies. So it's to understand the function of current technologies for stimulating the nervous system. This, as you can see, it's not through NIDA, but it's the Brain Initiative. But we have signed on, so NIDA will fund applications through this FOA. So the contacts in DNB are Dr. Olivier Berton and Dr. John Fedota. You should reach out to them if you think your research focuses on sort of the earlier stages of neuromodulation research. And I want to emphasize, you should reach out. You can reach out to them if the research is not appropriate for their division, or they think it's somebody else in the division is more appropriate for what kind of research you're talking about. we all work together, and you'll be redirected to the best person to talk with. Next slide. So this is my division of therapeutics and method consequences. So we focus on development of therapeutics. We do preclinical and clinical. We're focusing on moving projects through preferentially the FDA authorization pathway, but we understand that interventions can get out there and be effective as just in general use through physicians. But we do have a funding opportunity that's specifically focused on neuromodulation and device-based treatments. This is a two-stage, it's a UG3, UH3. And again, this is a 2-year followed by 3 years. We have milestones in UG3. As I mentioned, it is to de-risk the project. So we'll take on projects that are more risky. You provide some validation or feasibility research. And then if you meet the milestones that are determined for the UG3, we can then go in and fund the UH3, which is generally for more funds and would include, say, a larger efficacy trial. So the contacts for this are myself and Dr. Will Ackland. So, if you think you're at that stage of your research, please reach out to us. We'd be glad to talk with you. And next slide. So Division of Translational Initiatives and Program Innovations, or TIPI. So as I mentioned, they focus on small business grants and small business technology transfer grants, the SBIRs, STTRs. They also do preclinical and clinical. They have funding opportunities that don't, again, these don't focus on devices, but they, the first one, developing regulated and therapeutic diagnostic solutions, devices are a very high priority for this funding opportunity. And it's also specifically focused on opioid use and stimulant use. And then there's the Blueprint MedTech Small Business Translator, targets translational neurological device development. And but again, their funding of devices is not limited to these FOAs. And if you think that you're thinking about a more commercial end of developing interventions, they are the people to reach out to, and you should contact Dr. Stacy Gutowski and Dr. Leonardo Angeloni. Next slide, I believe is the last one. Yeah, so just a few final thoughts. So we define neuromodulation broadly, includes central and peripheral interventions. We're very, very interested in neuromodulation research at any stage of development. We are more than ready to talk with you about your research, and really reach out to us. That's really our job, is to help you figure out how we can support your research and move it forward. So Hamid and everybody, thank you so much for giving me this time.
Thank you very much, Kevin. It was really, really exciting. And I've always found you really welcoming anybody who is interested to do something meaningful for developing new treatments for drug addiction. And thank you very much for helping us during many years of kind of your active service in NIDA. And thank you very much for your public service. Now we just move forward to kind of open the discussions and how we might be able to move forward for the next level. Just a few kind of last slides. We are running a live systematic review right now, basically doing a surveillance on all the publications that people are doing for neuromodulation for drug addiction. We already have 67 TS trials published in the field of drug addiction and 104 TMS trials in the field of drug addiction. So it seems that people, I mean, there are many ongoing efforts in terms of bringing neuromodulation technologies to addiction treatment, and people are using different outcome measures. As you can imagine, drug craving is the most frequent type of outcome measure that people are using in TS-TMS trials, but things like drug consumption, other things are also considered as major outcome measures that people are using. But I mean, people are targeting different parts of the brain, so there are different discussions about what could be the best target area for drug addiction. And also, one of the exciting things is people from different countries that are right now contributing to the field. So of course, US is the leading country in the field, but people from China, from Brazil, from Italy. So you can see that people from around the world are contributing to published trials in TMS for drug addiction. And that was basically one of the main motivations for us to bring people together to develop what we call International Network of TMS Trials for Addiction Medicine. And with Colin Hanlon, we have been kind of able to bring people together and see how we might be able to help people, not only in the US, but also across the world in other countries, to see how we can have high quality research in the field that could be accumulated to end up to a real meaningful interventions for people who are suffering from drug addiction. We published a sort of a roadmap paper in 2019 discussing about what people need to do and what are the things that should be done in the next steps. And just few years after the initial publication, now we realize there are many new emerging topics that we need to cover. So right now we have started to discuss to publish basically the second roadmap paper discussing the emerging topics that we have during last 2-3 years of the really rapidly progressing and developing field. So it is really exciting to see that we need to go for the next roadmap paper for this. And we are right now working on that in terms of kind of the developing the outline, and we are discussing about that. And if you are interested to contribute on that, at the next roadmap paper, you are definitely welcome to join us to that discussion. Now, I mean, the floor is open for further discussions and questions and how we might be able to collaborate and how we might be able to do things together in the future. As you realize, in this talk kind of setting that we had today, we had presenters from 10 different labs across, mainly in the US and also in Europe, that are actually doing neuromodulation interventions, mainly with drug addiction. So you can see that there are many labs that are interested. So if your lab is also interested, please join us in this network. And also you realize that most of our speakers today are young investigators. So they are going to be the next leading investigators in the field. And that is something that makes me really excited about the field, because seeing lots of really young faces that are emerging as shining stars in the field, and they are motivated, they know what they're going to do. And that is one of the really exciting opportunities that we have in the field of neuromodulation for drug addiction.